Introduce your team and your case.
Okay, nice to meet you again, Dr. Cohen, Dr. Zhang, Dr. An. My name is Hyeon-Cheol Gwon from South Medical Center. I'm cooperating with Dr. Song, Young-Bin Song, and Jumeng Lee. And so before starting introducing our case today, I'd like just to show you just a bit of the previous angiography, because it was done in the structural theater, but it was a coronary case actually. Severe aortic stenosis presented with the chest pain, but we found a severe circumflex osteal lesion. But at that time, we have just 35 minutes, no time to show the final picture. So it was not so problematic to guide the guiding catheter into left main after implanting the Sapin 23 millimeter guiding. So we used the XP 3.5. Then, actually, as you can see, that the wiring is challenging. I tried first with the run-through wire, then next. It was not so successful to change to a UB3 wire. It's a stiffer wire to keep the curvature. So we tried for 30 seconds, then finally got through. Last, 마지막 slide. So this is an 81 years old lady after TAVI procedure. So I don't like to finish with a complete perfect result. Just the 2.5 balloon, 2.75 DCB was done. So this is final result. Okay.
Okay. Good job.
Thank you very much. So Dr. Lee introduced our case today.
Okay. Let me introduce
Dr. Song, sorry.
Today's case. Next slide, please. This is a 68-year-old male patient, and he presented with exertional chest pain for 5 years, and this pain was aggravated recently. Chest CT in medical checkup found severe calcification in 3 coronary vessels. He was taking antihypertensive medication. Echocardiography showed that the normal LV ejection fraction with the inferior hypokinesia. Stress echocardiography showed that the hypokinesia in anterior and inferior wall and total exercise duration was nearly 9 minutes. LDL cholesterol level is slightly higher, and anti-proBNP was slightly increased, 286. Next. Chest CT showed that very severe calcification in 3 coronary vessels. Next. Electrocardiography ECG found normal sinus rhythm without significant ST change. Next. A baseline coronary angiography showed that severe calcification from proximal LAD to mid LAD. And as you can see here, there is some collateral flow from LAD to right coronary artery. Next. Also, significant calcification at proximal LAD to mid LAD. There is some diffusion luminal narrowing at Ramsey intermedius. Next. Actually, the right coronary artery is TIMI1 flow at total occlusion at mid to distal right coronary artery. Actually, yesterday, Dr. Gwon presented this case at video demonstration session. And next. Okay.
Okay, so this is a severely calcified lesion, and especially in the LAD and the RCA. The RCA was pre-treated with rotablation, just 1.5 millimeter bore, because the artery was big, but the calcifications are not so severe. In this case, we have more severe calcification in the proximal LAD, extending to left main. So still, I prefer rotablation, and many of you can think that we can do with the cutting balloon, do with the scoring balloon, and any other methods. And maybe in Eastern Asia, I think in another country, maybe lithotripsy is one of the choice, but crossing the stent, crossing the balloon is a challenge too. If I choose rotablation, what size of burr do you need? Just 1.5 millimeter for plaque modification, or larger burr to educate the stent expansion. As you know, during rotablation, we have no way to protect the side branch. We have, as you can see here, we have 4 branches here: circumflex, first diagonal, second diagonal, third diagonal. I don't think we can protect all the branches. How to do that? And what's the best standing strategy? What's best imaging modalities? Actually, as you know, the Dr. Jumeng Lee and the Song has recently published the Innovate Complex in NEJM, the role of IVUS and OCT. Maybe it'll be interesting to compare the IVUS and OCT in this case. So it's not up to you for the discussion.
Okay. Too many questions. Okay. Let's discuss from the panel.
Well, hello, this is David Cohen. Thank you, first of all, for inviting me here. And this is really a challenging case you've picked out to show us. I'm more concerned about the side branches than the main vessel. I think the main vessel will be fairly straightforward, especially with rotablator. I think in the U.S., we may well these days have used IV lithotripsy for this, but you would never be able to pass the balloon initially. You would have to do something before. If it didn't predilate, you'd have to do rotablator and then lithotripsy, so it's very challenging. My inclination would be to use a single small burr, 1.5 burr, because I don't want to occlude all the branches before I have a chance to protect them. And then I probably would put wires in the second and third diagonal and then stent. But that's me. We'll see how everybody else thinks.
So in case of lithotripsy, is there any data that you can break how millimeter depths of calcium? Or
I don't think there's very good data now. Again, usually we do that if we can't even cross with a balloon. Then we need rotablator, and then we need to, and then we want, it's very heavy calcium. We want to really expand well for a large vessel. Then we would use IVL. But I don't think there's any good data on it at the moment. Okay. We await many registries to teach us.
Okay. Another comment from the panel? So
size of the burr? What do you prefer? Just 1.5 or 1.75 or larger?
Or before rotablation, do we need intravascular imaging? How do you think?
I don't think so.
I don't get it there. That we always said that was the poor man's IVUS. If you couldn't pass the IVUS, then you need a rotablator. I think that's still the case. Okay. So I think you imaged later, but you not first. I think.
Okay, maybe I can help you with showing just today's first image. Okay, good. Put on the screen, please.
What size guide? Is that a 7 French guide?
This is a 7 guide catheter. Yeah. So my plan was that in the RCA, I just used 1.5 millimeter burr because the calcification is not so severe. But for LAD, even after the crossing the stent, the expansion is not really guaranteed, I think. So LAD, I try to offside the burr to artery ratio near to 0.5. This at least 3.5 millimeter artery it should be. So I choose 1.75 of sizing. Start with 1.5 and actually 7 French XB 3.5 guiding catheter. Actually, there was a pressure dampening during the guide engagement. So we put the wire down there with It's a rotawire, right?
Yeah.
그전
Previous.
제일 앞에 걸 달라니까.
오늘 제일
앞에 거. Okay. So it was easy to get the run-through wire down there. Next. Exchanging was difficult. I first used the fine cross microcatheter. It couldn't cross the medial lesion. So what do you prefer at this time? How do you overcome this situation?
1.25 first?
No, I
1.5.
just. Are you
It's a
saying that?
microcatheter.
Yeah, you just to exchange anyways. You're very close to the end, I think. So you can
Right.
just
I think you can exchange.
go with the rotowire now.
Right. So next, I exchange to a microcatheter, the better microcatheter, hopefully.
okay.
The Corsair is extra small, but it could not cross either. So there is three options here. So put another wire and pull back and try microcatheter again. Secondly, 1.0 balloon dilation, then try to put the microcatheter down. And thirdly, as you suggested, just pull out the wire, then reinsert the rota wire. Next. So, rota wires coming through. Fortunately, the most severe lesion was at the distal end of the lesion. So it was quite easy to get the rota wire down. Yeah. Okay, next. So now we can get the angiography, very severe calcification, definitely severe calcification. Next is the auriocranial view.
So is your plan to go first with the 1.5 burr and then 1.75, or straight to a 1.75?
I think 1.5 or 1.25 is better. The 1.75, it'll be
Long time.
take too long time.
I agree.
And do you think we need a predilation of a first diagonal before the rotablation?
I hate putting a wire and then taking it out and putting it back. It's going to look bad no matter what, I think is the problem.
Even diagonal branch looks calcified.
Yeah, I think I would try to get away without it. I really would. But we, I think there's a lot of room for judgment here. And if you're, committed to saving all these diagonals, I think the first diagonal and the third diagonal are the biggest. So.
Right. So I think maybe you can predilate, but I think we can. Finally, we finish with losing some one or two diagonals, and we can tolerate that. Anyway, we try to next dilate the first balloon. Try not to make a dissection. Just a 60 atmosphere, 2 millimeter ball, the 2 millimeter balloon. Next. So this is angiography. Hopefully, we didn't make a lot of dissections there. So here we are. We are now starting the rotablation, 1.5. This is RotaPro. The RotaPro is launched 1 or 2 years ago in many countries, but in Korea, just launched 1 month ago. In August, there was we have RotaPro now. Okay, I can go ahead with the rotablation, and we can discuss and make a question.
What's the difference of RotaPro?
Yeah.
What's the difference against the previous one?
The main difference was that the push button is on the advancer, not the foot pedal.
Oh, okay.
So it's easier to control, but if you are familiar with the previous version of rotablation, so it's kind of strange, and it's time to be familiar with. But just 1 or 2 cases, it's all the same. And the console, can you show us the console? The design was console was beautifully changed. Okay.
We don't see it yet.
Okay.
Showing us the console?
We are not seeing the console.
Camera.
There we go. Now we see.
Oh.
Yeah.
Okay.
보이고 있습니다.
Good.
So the Dynaglide on 해줘요. On.
네.
Yeah. Push the button on the advancer. Yeah. Stop. Yeah. 잠깐만요. Dynaglide 끄고.
네, 이것도 다이나 같아요.
And set to 190. Okay. On. Dynaglide 말고.
누구?
네.
190. Usually I start with 180 or 190. In this case, I try to stop. Okay.
잠깐만요, 선생님. 네, 됐습니다.
Okay.
다이나 할까요?
다이나하고 와이어 팁으로 생이 잡아야 되고
네.
딱 돌지 않도록 잡고
네.
생이 이거
자, 이거
누르고
누르시면 됩니다.
이거 좀 잠깐
예.
스탑했네. 오케이.
Very busy.
Actually, they are all first operators. So we are now working together. It's the first time we're working together. I don't have a second. Yeah, on.
One.
Okay. Push on the dynaglide, and it's very easy to advance the rotable. Okay, here's platform. So left main is a little bit diseased, and I think 조금만 움직일게요. I think we don't have a very good platform in the left main. So my routine procedure is just test ablation for about 3 seconds. Dynaglide 빼고 3 seconds, then see if we need a pacemaker or a filling. So let me start a few ablations. Oh, sorry.
플로우도 좀 밟아줄래? 그쪽.
잠깐. 네, 플로우를 밟을게요. 오케이. Then watch the blood pressure. It's going down a little bit, but no block, no severe bradycardia. Okay, I go with without aminophylline or any other pacemakers. Okay. 가이딩이 좀 약하다. 가이딩 좀 넣고, 오케이. 이게 좀 걸리는데?
좀 걸리네.
네, 릴리스 해주고, 오케이. Yeah, blood pressure is quite stable, and we need to actually, the wire should be very deep down there. During rotablation, if you hold the wire, then rotablation, it is easy to push the wire down. Okay. Yeah, this is the tightest portion. Okay.
That's a very severe area there.
You're right. Maybe 1.75, where I think we'll never gonna pass it. The pressure is going down a little bit.
Yeah. No chest pain?
가슴 아프세요? 가슴 아프세요? 아니요. Yeah, no chest pain. Okay. And go very slow. Actually, at this moment, this angled portion,
Yes.
there is higher risk of blood trapping there. So we need to very slow. I'm not supposed to push it too hard.
Yeah, I didn't think it was going to be that easy.
Sorry?
No, it's okay. Go ahead. You
Okay.
you work.
Yeah, I work. You discuss it. Very resistant.
Yeah. That's that. Can you show us the previous angiogram just to see what that area looks like?
Yeah.
어.
And
Previous angel.
Right.
cranial.
Yeah, it's just before the diagonal.
Right. Yeah.
It is very severe calcium.
아미노필린 좀
Wow.
줄까?
예?
아미노필린? 약간.
아미노필린이요?
그래서 a little bit.
아미노필린 준비는 돼 있어요.
잠깐만 테스트 해볼래요? 테스트? 플로우? 테스트? 예, 가이딩 다시. 오케이, 테스트?
됐어요?
Yeah, flow looks okay.
Flow is good. Yeah.
Okay.
That is just.
P를
우리 하이드레이션
20만으로 좀 올립시다. I'd like to increase the RPM to 20,000, 200,000.
Is your pressure damp?
Pressure.
Yeah. Okay.
Yep. Okay. 좀 더 올리고 20만 더 20만 더 sound changes.
Yeah.
Okay.
It's loud there. Almost.
Whoa.
Wow.
Very hard. So blood pressure down, getting down.
Do you think you might want to go down to a 125 for that spot, or you keep try a little bit more?
Yeah, I think that I like to leave it to the last result. So
Yeah,
if I try 3 more times,
Yeah, no.
if
1 to
I
5
fail
might
the
be
test,
better.
I mean,
yeah.
125 will go, but
Yeah.
you'll have to come back with the 1.5 anyways.
가슴 아프세요? Yeah, no chest pain. It changes a lot. Blood pressure a little bit down, but patient didn't complain of chest pain.
The last diagonal,
Okay.
the origin of the last diagonal, the first diagonal, comes from the very tight calcified lesion.
Very tough. Very tough.
Yeah, two more passes.
엑스트라 소프트 와이어로. 엑스트라 소프트
아니,
와이어.
괜찮아. 브라디카디아 계속 있네. 아미노필린 좀 쓸까?
네.
아미노필린 0.5 앰플 천천히 드립을 좀 해주세요.
Any comments
I
from
like
the
to use
panel?
aminophylline to maintain the blood pressure and the heart rate. We started dripping of aminophylline now.
Okay.
Let's see what happens.
You want to prevent bradycardia?
Bradycardia and hopefully hypertension.
Yeah.
Not improving the distal slow flow, but it's working. Blood pressure is marginal.
Ooh, you went through.
No.
There you go.
Wow.
Made it.
Thank you.
네.
The blood pressure is going down, so we have to wait a little bit.
이게 마지막 아니에요? 와.
Do you ever give just a little bit of neosynephrine?
주고 있어요?
Neosynephrine for these 100 micrograms for the blood pressure.
What? For the blood pressure, what? What did you say?
Oh, I was saying that we sometimes use neosynephrine, just little boluses, 100 micrograms.
Yeah. Maybe we can wait. I can tolerate the
I think it
low
comes
blood
up.
pressure now.
It comes to 90.
Yeah, comes up. Okay, let me change to the larger ball.
네,
다이나글라이트
누르시고
누르고.
이거 누르면 돌아가요 다이나가. 그거
오케이.
와이어 실으시고.
Yeah, 해요.
지금 와이어 눌러두셔야죠.
와이어 넣고. 그래서 it's not a good second assistant operator, but a very nice first operator, Dr. Song is. 그 자리에서. I didn't pull out the burr, as you can see here. Just let it come out. Okay, stop. Stop 시켜주고. Okay. So we have just finished, have done about 15 cases of Rotapro. So we are not so familiar with it yet.
It's mostly the same, just a few changes. So will you
Yeah.
take an angiogram here, see how the branches are?
Yeah, sure. That's what I'm doing. I will do it. 테스트. 살짝 가이딩 채우고 스톱. Okay, 엔지오.
네.
네. Okay, we have 4 branches here.
1, 2, 3. That's good.
1, 2, 3, 4. Okay, let me change to 1.75.
1.75.
But maybe you can.
1.7.
Exchange, Burman exchange.
네.
But we can exchange the whole system, but I prefer to 여기 좀 focus. I prefer to exchange the burr only. 이거 스탑 해주고, 물좀 스탑 해주고.
네, 지금 여기 있어요.
Okay.
예.
Okay.
스탑. 됐습니다.
Okay. Yeah. Burr is free now.
가져오고.
1.15.
1.15.
예, 똑같이. 요 껍질 뺏기고. 예. Okay, this is a 1.75 burr. 좀 끝에 잡고. You need a very nice vision here.
불 좀 켜줄 수 있나요?
So there's some fairly significant disease in that proximal circumflex. Was that spasm or was that there before and I didn't notice it?
Yeah. So actually, in the obtuse marginal, there is very long, about 50% stenosis there. But I don't try to touch it because if I touch that, we need a two-stent technique.
No, you're going to
with
need
a very
a lot,
long
yeah.
stent.
Yeah. No,
Okay.
it's-
물 좀 열어주고.
예.
Dr. Gwon, will you check the proximal circum?
Circumflex, previous angiography, please. Epicaudal. Okay. There is disease there, down there.
I think it's just diffusely diseased. It's just a lot of disease. Maybe some nitro after the blood pressure comes up.
Yeah, actually, it looks now okay in the proximal portion of the obtuse marginal. Maybe you can, it's stentable. I don't try to cover the ostium of the circumflex, but the previous angiography, it looks very diseased in the proximal ostium of the circumflex. It not comes better.
Yeah.
So
No, you have
we
room.
can finish with a 2.5 stent. Okay, I can do that. Before stent crossing the left main, right? Anyway, we are finished with the rotablation here.
Putting the balloon on the rota wire is still the hardest part of the whole procedure. So, the wire, the rota on the wire. That's why I do structural. I don't like these 009 wires.
Yeah, even I lost it.
Sorry, maybe I jinxed you.
Yeah. It's very difficult to see it.
No, that's why old interventionalists like me do structural. We get 035 wires. We like that. That's very nice.
Okay. Yeah, so can you see the blood pressure here? It's coming back to about 100. Yeah, partly because of the time and partly because of the aminophylline. The heart rate is a little bit faster. Okay.
Looks good.
Blood pressure looks great.
17. 셋 늘어놓고 17만 온. 다이너갈 빼고
다이나 뺄게요.
네? 온. 17만. I set it to 170. Maybe 160 is okay, but stop. Dynaglide. Okay. Yeah, I'm coming in. 뭐?
거기서 걸려는 것 같아요.
아니, 다시 한번 눌러봐.
네. 거기 어디서 걸려요?
프렌치인데? 프렌치 가이딩 맞지? 다시? 오케이.
I think you should look the guiding catheter.
Okay. 눌러. There is some resistance because of the angle. Guiding catheter may be a little bit compressed down there. Now it's okay. on the platform. Okay, 하나 빼고. Okay, you're going in. 있다. 여기. Yeah. Oh. Yeah. The pressure is not getting down.
Oh, it's good.
After aminophylline. I think it's the effect of aminophylline.
Yeah.
Okay. 계속 장이 걸리는데, 이거. Okay.
Much easier.
It's much easier. Okay. Now polishing one. 하나 안 찍어 넣어도 되겠죠? Polishing one. Actually, do you believe in the low-speed polishing run, as suggested by the Japanese doctors?
I've never done it. I just keep it on the same speed.
Actually,
do you mean low-speed rotation or just going slowly through the lesion?
Slowly.
Oh, I usually go kind of slow. Yeah.
Yeah. 14만.
I don't know if it does anything, but
Yeah. Let me set to 140. Yeah, actually, in the paper they recommend 110. Actually, what is going on in Japan is 130 or 140. Okay, let me try the 140 polishing run. The purpose of low speed, the polishing run is making the burr as big as possible. It's a little bit 0.2 or 0.3 millimeter larger, but not concentric, of course.
But the particle size might be bigger.
But this is the polishing run, so that's not be the problem. So
Okay. Dr. Gwon,
Yep.
thank you for your beautiful rotablation. May we go to the Seoul National University and come back again?
Yeah.
Okay, thank you.
Okay. Thank you very much for coming back. So we are just finishing the stent in the left main. Afterwards, I'd like to show you the IVUS and OCT findings together. Okay. Today's a special test.
Yes, sir.
Okay. 좀 뽑고. 테스트. 오블레 충분하지? Inflation. 8.
What size is this?
Yeah, 3.5, 28. The 10, 12. Okay, deflation. Epicoder. And the path tester. Inflation. 18. 20. Okay, deflation. Okay, we put the stand 3.0, 14 millimeter science stand in the LED, and the 3.5, 28 in the left main to LED. Actually, the stand length was longer than I thought because we have some event after you go. Okay, so firstly, I'd like to show the IVUS after rotablation angiography.
엔조 먼저.
Angio. Okay, this is angiogram after rotablation. Okay, quite acceptable. We
so
didn't
that's
lose
after
any
the
branches.
175 burr.
Okay.
Yeah.
175 burr.
Yeah.
Right. IVUS, please. IVUS on the screen. Usually, I prefer IVUS, and Dr. Jumeng Lee prefers OCT. So we did it together. Okay. IVUS, the vessel size is about a little bit larger than 3.0. This is the diagonal. Yeah, this is the napkin ring, the most tight lesion, and the angle of the medial AD. It's getting better. I cannot identify the vessel size exactly, but at least 3.5 or more. This 360-degree calcification proximally again. Maybe this was the first diagonal. Here comes the circumflex. You can see the wire in the 8 o'clock. Left main is a little bit diseased. The vessel size about 5. And finish up with some calcification in 11 o'clock. Okay, OCT. Let's look. Let's see how different it is. Dr. Lee?
Yeah. Can you show up the OCT? And put the play button.
On the screen?
Yeah.
Main screen? OCT 올려주세요, 메인으로. Okay.
Okay. We got it.
Would you play OCT? Yeah, the OCT pullback was done from mid LAD level, just below the heavily calcified lesion. And can you see the calcium chunk started from here? And huge calcification,
Yeah, wow.
360 degree. And we can see some cracks on the calcium after 1.75 millimeter burr. And this one is some calcium nodule plus calcium spicule after the rotablation. And still heavily calcified segment. Yeah, we are approaching the proximal LAD. And this one is the circumflex, and now left main.
So can you measure the thickness of calcium in medial AD?
Yeah,
Can you show
we
the
measure
medial AD?
the maximum calcium thickness. Yeah, here is about 126 micrometer. And can you show the next frame? Yeah, in here, 143 micrometer. Yeah, as you well know, calcium thickness more than 0.5 millimeter and the length more than 5 millimeter. It's strongly support the advanced lesion preparation like rotablation.
So, Dr. Lee, the OCT is more expensive than IVUS. So what's the advantage of OCT in this case?
Yeah, actually, OCT is not more expensive than IVUS. It is
Really?
kind of very similar price, including doctor's fee, even in US.
In Korea?
Yeah, in Korea, both modalities are around $2,000.
The disadvantage is that the vessel size measurement is not so clear in OCT, right?
Yeah, that's right. We are more used to the IVUS to measure vessel
next.
size.
Done.
But you can see the clear calcium extent and
Okay.
thickness of the calcium.
Yeah, angiogram on the screen, please. So during inflation with 2.5 or 30 millimeter ballooning, actually balloon ruptured. Yes, I asked Dr. Lee why this balloon ruptured. Give me the reason. So OCT on the
Can
screen.
you show up the
OCT?
OCT? Yeah.
Calcium spikes?
Must be.
Yeah.
Yes. Yeah.
OCT on the screen.
There were huge calcium spicule
Yeah.
in this around 6 o'clock
Yeah.
direction. Yeah.
So solve my curiosity. This is the only reason today. So next angiogram. Next, I extend to 2.75.
NC?
Sorry, NC balloon,
Nice.
20 millimeter, pressure up to 18 atmosphere because it was not well expanded. It's a little bit oversized, right? Next. Yeah. Next. 18, 20, next. So angiogram. What's happening here? You can see
section, yeah.
some haziness,
Yes, distal.
in the distal LED. So IVUS, please. 그다음. So this might be a hematoma. This might be a dissection. So we did IVUS again. You can see a hematoma down there, right? It's compressing the artery. And it's extending up to the previous severely calcified lesion. You can see still some so-called dioma, right?
Yeah.
The low density in the 12 o'clock to 6 o'clock. So next angio, next. So I tried to remove the hematoma up to the original position. Next.
balloon.
So I did the balloon again, very low pressure, 5, 6 atmosphere for 1 minute. Next. What do you expect? Next. It didn't work. It didn't work.
When you have
Anyway,
a
sometimes
hematoma,
we have a hematoma. We put the stent, hematoma
Yes,
is migrating to downwards. So I think I routinely do this kind of procedure to release the hematoma up to the lesion, up to the original approximately. So I put the stent next. This was the 3.0, 48 millimeter Zion stent. Next, 8 atmosphere. This considering the size and the side branch, side branch collusion. Then 10 atmosphere. This is the angiography afterwards.
Still have all your branches. Nice.
Yeah. Still we have branches.
Yep, all 3.
Yeah. Next. So we put the next. So next one is 3.5, 28 millimeter, 28 Zion stent. So we are just about to take the angio. Epicranial. Please count the diagonal for me. I don't know. I cannot say that. 다리 좀 채우고.
네.
Stop. Okay.
네.
One is
One missing, the proximal.
missing. Yeah. Let me ask a question. The chest pain. 가슴 아프세요 지금? 괜찮아요?
Yeah.
No chest pain. Surprisingly.
That's nice.
so you are losing one branch due to the overlapping stent?
I'm not sure.
Yeah.
I'm not sure. Anyway, in that first diagonal, that portion is not well expanded here, so we need a further expansion at the expense of the no coming back, the branches coming back. Do you want me to do that?
I think you need
proximal?
to post-dilate. Yeah, I think,
Yes.
I think you do.
Okay. Post dilate
You already lose.
3.5, 3.5,
3.5,
3.5,
20점.
NC 20 주고 메인도 해야 되는데. 물론 많이 든다. and the part in the main with the 4.5.